Welcome. This is going to be a podcast about a recent publication in the North American Spine Society Journal about epidural lipomatosis. And it's great to be joined today by Dr. Holder, who is the lead author on that. I'm going to be conducting this. My name is Jonathan Grauer. I'm editor-in-chief of the North American Spine Society Journal. So welcome. Dr. Holder, can you introduce yourself?
Thank you. Yes. Yes, my name is Eric Holder. I'm a podiatrist, a physical medicine rehabilitation physician in the Department of Orthopedics and Rehabilitation. I mostly practice outpatient in musculoskeletal care, focus on interventional spine, just general MSK care. So it's certainly great to be here, and I'm really happy to talk about this subject matter.
Great. And before we kind of get into the meat of kind of your review that you did, maybe you just tell us a little bit of background about epidural lipomatosis.
Sure. So epidural lipomatosis, it essentially refers to an abnormal excessive accumulation of normal unencapsulated epidural adipose tissue, in the epidural space. And this has the potential to result in narrowing of the spinal canal due to hypertrophy of mature adipocytes. It was first recognized in approximately 1975. There was a physician that was caring for a patient after a renal transplant, receiving chronic systemic steroids, and over time developed this condition. And ever since then, there's been some evolution in the literature regarding it. There's four major categories that it revolves around. Those four categories are exogenous steroid exposure. And really, when you think about exogenous steroid exposure, you're thinking about long-term systemic steroid exposure, whether that's intravenous or PR. That's the most commonly cited reference when we're talking about exogenous exposure. Then you start the other category that's been frequently associated is obesity. Then there's endogenous steroid overproduction, and usually you're thinking along the lines of Cushing's disease, and then idiopathic. Idiopathic, when you read about this in the literature, it's very variable. They use the term very variably, but generally, most would state that this refers to the development of epidural lipomatosis in patients that are non-obese and do not have any known predisposing risk factors.
Great. And, in terms of just clinical practice, again, as we kind of get into the paper, just to put this in context for those listening, how do you see patients with epidural lipomatosis typically presenting to you?
Yes. So most of the time, it's important to note that this is usually an incidental finding. So you order an MRI, you get a study, and then you see, this finding of epidural lipomatosis, and it may have no direct pertinence to the patient's symptoms. However, if they are symptomatic, they can present with a variety of symptoms. As pertains to the lumbosacral spine, there's been documentation in the literature that it can present with low back pain or low back pain with radicular features, potentially present with neurogenic collocation similar to patients with osteoligamentous degenerative stenosis, can present with cauda equina if it's severe enough. It's also notable that it has been shown to be involved in thoracic spine as well, and if it involves the thoracic spine, that could present with myelopathy. And I think what's an interesting point about this is that, we really have to also consider the severity, right? So in milder cases, there was actually a study in 2003 by an author named Boré and colleagues, and in milder, they formulated a grading system, basically from grade 0 to grade 3. And it's probably the most commonly cited grading system as it pertains to epidural lipomatosis. And what they determined is that grade 0, meaning normal, grade 1 being mild overgrowth of epidural adipose tissue, grade 2 being moderate overgrowth of epidural adipose tissue, and grade 3 being severe overgrowth of adipose tissue in the epidural canal space. They basically did this by assessing the ratio of the dural sac to the epidural fat and the ratio of the epidural fat to the AP diameter of the spinal canal. Now, why this is pertinent is because they noted that most patients that have grade 1, or mild epidural adipose excess, most were not really symptomatic. Really, none of them were found to be symptomatic. Versus grade 2, which they found that of those grade 2 patients, only 14% of those are actually found to be symptomatic. In grade 3, they found the least cases were grade 3, about 2% of cases, and all of those are found to be symptomatic. So it's important to kind of have a degradation in your mind regarding the severity when you start to think about symptoms and whether or not there's a direct correlation between lipomatosis or other factors that could be causing the patient's.
Right. And I have to say that most of the time when I think of epidural lipomatosis, I do think about it for higher BMI patients. I certainly very quickly acknowledged the exposure to systemic steroids made sense to me. I hadn't even thought about a potential association with injected steroids, which seems to be the focus of your study. Maybe you can kind of tell us a little bit about kind of what led to that and kind of the meat of what you guys found.
Absolutely. So the same for us. This is an area of particular interest of mine and the co-authors, because in clinical practice, you often see patients coming in with this condition, and there's a lot of variance in interventionalists and whether or not they're willing to perform injections in these scenarios. And there's also some variances in terms of referral patterns for these patients for injections and such. So we really wanted to take a really deep dive in the literature and just get a sense of what's out there. And we tried to also kind of go across disciplines to see, not only in the interventional spine literature, but what are folks talking about in the endocrine world and other things. So we found that there certainly have been associations made between lumbosacral epidural injections and epidural lipomatosis. However, it's pertinent to say that most of these studies are small studies, are all really retrospective. And there's often a lack of critical data that would be really helpful to understand this relationship. When it came to the injections, when the data was provided, we found that there's a large variability in the number of injections performed. Prior to the reported progression of the development of the epidural lipomatosis, we actually found that studies implicating it with one injection and another study implicating it after 103 injections. So a huge variability. We found that there is also significant variability in the dose of the steroid utilized, and in all cases, when that information was given, which was not in all cases, but when we did have that information provided, it was uniformly particulate steroids that were utilized. And we don't really know at this point whether there's a difference between particulate and non-particulate steroids and the potential risk of developing this condition, but it was notable that when the information was provided, it was particulate steroids. Timing was also extremely variable as well between injections.
So, I guess when you think about many injections, then that certainly is exposure over time. But did you take away the thought that, did it convince you in reviewing the literature that even after just a handful of lumbar injections, this might be something to have in the back of your mind?
I definitely think it's something to be aware of, but I definitely think that at this point, because of the limitations in the literature, attributing causation, it would be difficult at this point. The other thing too is that in many of these studies, when you look at it, a lot of them had independent risk factors or associations with the condition already, whether that was diabetes or hypertension or hyperlipidemia. All of these things have been associated with the condition, and some of the authors, paid attention to that. Others did not pay much attention to it and the association. And I think there's also evolving literature at this point regarding the association with metabolic syndrome and the correlation with epidural lipomatosis, which is a more recent area of investigation. And I think that may help to explain some of the interrelatedness amongst these conditions that we found, and maybe potentially be related to patient susceptibility to having this condition with steroid exposure, whether that's systemic or via injections. But we really need to know more. The literature is limited. There are no prospective studies about it, so further evaluation is needed.
Right. So maybe it makes sense at least to have in the back of your mind that certain people may be at risk in getting an injection. But how about if somebody comes to you with epidural lipomatosis? If they come in with neurologic symptoms with a concordant finding of epidural lipomatosis, it's thought to be a contributing factor. Do you think that, is your read that it's appropriate to think about injections in that populations? So
I think this is where the nuance kind of comes into it. And I think, there's different classes. So if we consider a patient coming in, obviously if they have neurologic compromise, and they have, pronounced marked, let's say grade 3 Barré, grade 3 epidural lipomatosis. In that scenario, surgical evaluation and consideration is absolutely warranted, I would say. For patients with, let's say, presenting with symptoms and findings consistent with neurogenic claudication, and then you have a patient that actually has significant overgrowth of epidural lipomatosis, which is the primary contributing factor. I think based on what we've assessed from the literature, most would advocate, avoiding steroid exposure, whether that's systemically or via an injection, and trying to address any modifiable risk factors, whether that's weight loss in an obese patient or if the patient has any underlying endocrinopathy, addressing that, and utilizing other conservative measures such as physical therapy to help maximize function as best possible, non-steroidal anti-inflammatories, neuropathic pain medications. I think where it gets really interesting, though, to me, is when you have the patient for example, a case scenario, you have a patient coming in, let's say, with a classic L5 monoradicular presentation, no overt neurologic deficit. And you begin with conservative management, let's say physical therapy. Let's say we try non-steroidal anti-inflammatories, potentially neuropathic pain medications as needed. They get a complete, comprehensive, appropriate course of physical therapy. They're still symptomatic. Get an MRI of their lumbar spine, and you absolutely see an L4, L5 disc herniation resulting in subarticular neurite, impinging an L5 nerve root, concordant with their symptoms. But incidentally, you also see that they have, let's say, mild degree epidural lipomatosis. Now, in some papers, they advocate, if there's any suggestion of epidural lipomatosis, completely avoiding a steroid injection, while others say, well, maybe we could try one just to kind of get the symptomatic patient feeling better. I certainly think in this scenario, one could argue that what is the only other alternative we have at this point would be consideration of surgery, given that they have failed all of the measures. And if it's a mild grade epidural lipomatosis, and we know that an injection could potentially help get them over the hump and continue with their therapy program and also addressing any modifiable risk factors, one could argue that's very reasonable. And we also know that there's, in the studies that implicated epidural injections as a cause, they often used higher dose steroids. And in present day practice, we often, for example, a transfemoral injection, we often use non-particulate at a lower dose than the reference doses used in the study. So I think there's nuance here, and I think further prospective study would be helpful in evaluating.
That's great. And one of the things you touched on, which I've always assumed, but I've actually don't know if I've ever read, is that if you take care of the kind of predisposing thing, whether it be related to the BMI or the steroid use, that if you start to get a hold of that, did you get a sense from the literature or just from your clinical practice that if you can reverse some of those things and address that the epidural lipomatosis will improve?
Yes, that's an excellent question. So that was one of the areas I was most interested in, because I'm not a surgeon, so my goal is to try and manage these folks conservatively and provide them with the best advice possible. And I wanted to see how confidently could I, based on what we know, can I provide this advice? And we do know that there are retrospective studies or a small, case reports or case series that suggest or implicate that if you, in a patient that's getting chronic steroid use, if you drastically reduce their steroid exposure or complete steroid cessation, that the epidural lipomatosis could potentially resolve and their symptoms could improve. There's also been some suggestion with addressing the modifiable risk factors, the metabolic derangements, there's potential for improvement. But there's no prospective long-term studies on this. There's no prospective comparative trials on it. So although there are clues, we still need to evaluate that further to be able to inform our patients more confidently.
Because it does make you wonder, if you did trial an injection, kind of coming back to that injection question, that kind of comes and goes. And so even if there was a small risk, maybe if you did an injection, if it was able to get some temporary improvement, as you go further away from that injection, maybe your risk dissipates. I know it's kind of getting beyond science at this point.
No, I agree. I think that, again, the goal with we know that in present day we use smaller doses generally than those referenced in the study. And, potentially getting the patient over the hump and addressing those modifiable risk factors may be a treatment option for these patients and requires further investigation.
Fantastic. Were there other findings from the study or other thoughts you have kind of summarizing of things you'd like to have the audience be aware of?
I think for us, all the authors on this study are interventional spine physicians. And for us, this was really helpful to really get a comprehensive scope of what's out there on this condition. I think that at this point, we have clues that there's possibility, and a possibility of an association between epidural lipomatosis and injections. However, we really need further prospective evaluation. I think that there is further nuance required in this subject matter. I think the literature regarding metabolic syndrome in SLE is really interesting, and I think that once we hone that down further, we may be able to provide more definitive, constructive advice to these patients regarding conservative care. I think essentially there are a lot of clues that we have at this point, but we need to be able to have more definitive study to make more definitive statements regarding the subject.
Well, we look forward to you giving us more answers.
All right, very good. Thank you so much. I appreciate you bringing me on. And I'd also just like to thank my co-authors, Robin Raju, Mark Dundas, Emmanuel Husu, and Zachary McCormick for contributing greatly to this project as well.
Thank you very much for joining us today.